Hello, my name is Nicholas Lay, and my presentation is on Middle East Respiratory Syndrome, or MERS. So Middle East Respiratory Syndrome, or MERS, is a viral respiratory disease caused by Middle East Respiratory Syndrome coronavirus, or short for MERS-CoV. Coronaviruses are generally a large family of viruses that can cause disease range from the common cold to severe acute respiratory syndrome, or SARS. Here's a bit of history of the disease. So since 2012, the MERS virus has spread to nearby countries of the Arabian Peninsula, with all cases in other countries linking back to the Middle East. In Germany and the United Kingdom, they had reports of MERS as well. And in 2013, France, Germany, Italy, Kuwait, Oman, Qatar, Tunisia, and the Arab Emirates were added to the list. In 2014, Algeria, Austria, Greece, Turkey, Lebanon, Malaysia, the Netherlands, and Yemen showed MERS-infected patients as well. In 2015, Iran, Philippines, Thailand, and China all inhabited infected persons, with Republic of Korea harboring the largest outbreak outside the Middle East. So in this Republic of Korea outbreak, there was a total of 186 cases confirmed, with 36 deaths. In terms of prevalence, there's a relatively low occurrence of MERS in the US. In May 2014, the CDC confirmed 2 unlinked imported cases of MERS in the United States, once in Indiana and the other in Florida. So both cases were among healthcare providers who lived and worked in Saudi Arabia. Both traveled to the US from Saudi Arabia, where the scientists believe they were infected, and both of them were hospitalized in the US and later discharged after fully recovering. And according to the WHO, at the end of February 2022, a total of 2,585 laboratory confirmed cases of MERS, including 890 associated deaths, were reported globally. The majority of these cases were reported from Saudi Arabia, with 2,184 cases, including 812 related deaths. Mechanisms and pathology of the MERS virus are relatively unknown, as there have been no published reports of autopsies of fatal MERS cases. And what we do know is the basic spike protein interaction with the receptor. So the MERS coronavirus spike S protein interacts with the DPP4, which is a cellular receptor for the virus. And when the spike protein interacts with DPP4, there's viral attachment to the host that occurs with the virus cell fusion, which starts infection. The MERS virus protein then cleaves the host cell into S1 and S2 subunits, with the S1 engaging in the receptor while the S2 mediates membrane fusion. Once the virus is able to enter the host cell, single-stranded RNA is able to be replicated, and viral proteins are formed on new viral envelopes, and the virus is able to leave through exocytosis. The MERS virus is also able to counteract the early innate immune response through its inhibition of type 1 interferon. And this type 1 interferon is essential in the role of antiviral innate immunity, in which the MERS virus is efficiently able to inhibit the activation of type 1 interferon response. So here's the basic structure of the MERS coronavirus. So coronaviruses are generally characterized by their crown-like coronal glycoprotein spikes on their surface. And these spike glycoproteins are responsible for receptor binding and cell fusion. They're indicated by the large green structures on the outside. And the nucleic capsid phosphoprotein is responsible for managing viral RNA through binding, synthesis, and translation. They're indicated by these small orange circles. And the membrane glycoproteins are involved in cell recognition and binding, indicated by these brown structures. There's also small envelope glycoproteins, which basically do the same thing, and they're indicated by the pink structures. And the type of RNA is positive single-stranded RNA, and the viral envelope is responsible for protecting the RNA molecules, evading recognition by the immune system, and facilitating viral entry into the host cell. And it's seen attached to these glycoproteins. And this is a chart comparing MERS to SARS, as there's a bit of confusion as they're kind of similar to each other in terms of them being coronaviruses. So the two coronaviruses differ in their genomic sequence, with MERS virus being more closely related to the bat-derived HQU4 and HQU5 coronaviruses. And some other differences are that the MERS comes from the lineage C of the genus beta coronavirus, and SARS comes from the lineage B of the genus beta coronavirus. MERS is also uses a DPP4 receptor for transmission, while SARS uses a ACE2 receptor for transmission. And MERS also infects type 2 alveolar cells and non-ciliated epithelial cells, while SARS infects ciliated epithelial cells. Also, MERS induces a more pro-inflammatory state. It is less transmissible. It has a delayed innate antiviral response. It progresses more rapidly to respiratory failure. It has a higher fatality rate and is more likely to cause renal failure than SARS is. The disease is believed to have originated in bats, then transmitted and mutated in camels, and the camels then spread it to humans through a zoonotic transmission through droplet spread, physical interaction, or eating or drinking infected products. And once the human contracts the disease, there can be a direct person-to-person contact spreading to other people through droplet spread and physical interactions. And this is a diagram showing how humans contract MERS from camels. As mentioned before in the previous slides, bats are thought to be the primary host of MERS, and camels are most likely became infected when they ate food contaminated with bat feces, and humans then consumed infected camel meat, milk, or urine, and then humans passed the disease onto each other through direct person-to-person contact. Incubation period for MERS is between 2 to 14 days, and during this time, infected individuals are contagious. These individuals are even more contagious when they display symptoms, and these symptoms are often flu-like, including coughing, difficulty breathing, high fever, fatigue, and headaches. There can also be gastrointestinal symptoms such as vomiting, diarrhea, and abdominal pain. And in severe cases, the disease can even progress to pneumonia and renal failure. So diagnosis starts with an observation of symptoms within 14 days of traveling or coming in contact with someone who has traveled to an affected country. Once symptoms have been confirmed, molecular tests can then be done to diagnose an active infection. One type of test conducted by the state and CDC labs is called PCR, or polymerase chain reaction assays. And PCR assays are done with respiratory serum or stool samples, and they can quickly indicate if a person has an active infection with the MERS virus. And serology testing, this type of test uses serum samples and is designed to look for antibodies to the MERS coronavirus that would indicate that a person had been previously infected with the virus and developed an immune response, or has an active MERS infection for approximately 14 or more days. Currently, there is no vaccine and there is no specific antiviral treatment recommended for the MERS infection. So individuals with MERS often receive medical care to help relieve symptoms instead. And for severe cases, current treatments include care to support vital organ functions. And the only thing you can really do is social distance or wear protective masks around people that have recently traveled from the Middle East. You can limit travel to rural parts of the Middle East and avoid camels, avoid touching your face with unwashed hands, and you should sanitize frequently. those visiting or living in rural parts of the Middle East where camels are prevalent, these are some of the most at-risk populations. And though people of all ages can become infected, those with weakened immune systems, like children and the elderly, are most susceptible. And pre-existing conditions like cancer, diabetes, heart, kidney, and lung disease, these can also increase your risk of contracting the disease. With the virus being relatively recently discovered, there has not been much concrete research done. However, there are ongoing research efforts to develop vaccines and treatments for MERS. And although the MERS virus outbreak is more restricted in terms of transmission when compared to SARS, there is speculation that there may be future adaptations in which there is an increase in human-to-human transmission. Currently, there is no need to worry as the CDC and other public health agencies are closely monitoring the MERS cases, and they're working to coordinate global health responses, routinely provide updated information, and provide training for health authorities. These are my resources, and thank you.